That's it.
Now it's recording.
Now it's going.
Okay.
We're on.
Alrighty. So, thank you for coming. It's very nice of you all. What I was asked to talk about basically was anything I felt like. So I thought that gave me too much scope to sit here and blather. So we came up with a new topic, and it's new treatments. You know, what drugs are new this year, pretty much. And it's not a huge list. There's one that's very new, and a couple. One's a sort of a recycled formulation, recycled drug into a new formulation. Another one is a little bit out there. In terms of what's to come, I must admit I got a bit lazy. And by the time I got through the other bits, I thought, we probably need question time. So I'm happy to talk to it. Now, I don't know how I imported this, but this particular slide has nothing to do with what we're talking about tonight. But I do disclose that I have been a paid person. I have actually done some presentations for other people. I have actually been wined and dined and learnt things from overseas speakers at other people's expense. And I have done presentations for which I have been paid. However, the work is my own and it's unedited. So I've been lucky enough to be able to do that. So I don't feel I compromise my principles way too much. So the thought was that tonight we would talk about brexpiprazole, which is a new antipsychotic. We'd mention and maybe talk, if you wanted to, a little bit about paliperidone, but it's just a different formulation of a preparation that's been around for a while, and maybe suvorexant, which is a new hypnotic, and it's in a new class. So it's not a benzodiazepine, it's not one of those Z drugs, it's something, it doesn't work like melatonin, it's something completely different. So again, it's something to think about, and maybe we can have a bit of a think about the pipeline drugs. We've probably got one drug that's an antipsychotic that's close could be anything in the next 5 years, but given that our marketplace is so small and we're so isolated from most big marketplaces. So we've got one antipsychotic that's probably on the way. The rest of it is looking like a bit of a dearth. We're in the process that there's a lot of money in nibs and mabs, which are those cute new drugs for disease-modifying agents, for cancers and other diseases like that, where there's bucket loads of money. So a lot of money's been taken out of neuroscience development. But that doesn't mean there isn't any going on. It just means we're still a bit away from things coming to fruition. Okay, so if we think about brexpiprazole, and I compare it to aripiprazole. So brexpiprazole's marketed now as Rexulti. Aripiprazole is Abilify, okay, for those who don't know. If you look at the two, the bottom one pretty much looks like almost a mirror image of the one above. Big difference, only difference is, and I've walked off screen just now, is this little chloride group there. And on the top, it's a little closed ring. Now, you don't have to do much to something to change the way it behaves in the body, because you can change the way it's actually configured. And so the fit at different receptor sites can be quite different because of subtle changes, okay? But so far they look 6 of one, half a dozen of the other. Okay, so Abilify is one of the new dopamine system stabilising drugs. So basically brexpiprazole is an attempt to actually refine aripiprazole so it actually looks, so it doesn't cause as many adverse events. All right, so it's a bit nicer, it works just as well, but the couple of things that really bother people are taken out of the mix. Not always when you do that do you get exactly what you want, and you sometimes have to live with what you get. It's certainly indicated in Australia for schizophrenia at this point. it would be nice if it was indicated for psychosis, because that covers a slightly bigger gambit. And we know that aripiprazole is used quite frequently in bipolar disorder. So to think that this may have a role there is certainly possible. And it's also used as an add-on treatment in treatment-resistant depression, but not here. There's a reasonable body of evidence to suggest that it's actually quite useful in probably doses about half of what you're going to use in schizophrenia. So if you look again at what have we got? We've got aripiprazole that comes as an oral tablet. Overseas, they've got a short-acting injectable. We've got a long-acting injectable. Brex is only available as an oral tablet. It's quite likely that they will be trying to formulate it as a long-acting injectable, but it may be a 2-monthly preparation. So it's only 6 doses a year instead of 12. But that's to come. Both of them, we believe the mode of action is that they are dopamine, serotonin partial agonists. So partial agonists at D2. So we know D2 is associated with the symptoms of schizophrenia in different parts of the brain. Yeah? No? Yep. Okay, so, and serotonin 1A, which is a bit upbeat, seems to help, moderates some of the D2 stuff. It's also an antagonist at 5-HT2A, so serotonin 2A receptors, which is the process where our second generation antipsychotics seem to moderate some of the worst effects of the dopamine blockade. The other thing that's interesting is that these tend to have, like a lot of the second generation ones, a little bit more of a, we don't just stick on the receptor and stay there for long periods of time, they come on and off. So there's a degree of that to it. So still looking pretty much alike. Now, there is another slide I could have shoved in that I didn't, that gets all complicated because it shows like the different numbers and that. And what you can actually see is the most potent D2 partial agonist is aripiprazole. Brexpiprazole is in the ballpark, but it's just a little bit weaker. Having said that, it's still pretty strong. And where was I going with that? Okay, so when you start to look down amongst not just these receptors, but the other ones that we have that are implicated in psychiatry, so a range of noradrenergic receptors, cholinergic receptors, histaminic receptors, I mean, you name it. They've all got different affinities, and I think it's those different affinities that actually give you some of the subtle differences between them, that modify things and give you a slightly different picture of what they can do.
And I suppose the side effect profile naturally.
Yeah, look, most of the side effect profiles of these drugs you can pick from its pharmacology. When you get the detailed pharmacology and look at the inhibitory constants, which are fancy ways of saying how much drug you need to really hit this receptor, the lower the number means the less drug you need to do the job, so it's much stronger at that receptor site. You can see in some of the receptor systems there's like orders of magnitude differences between them, which means like 10-fold, 100-fold differences in potency at different receptor systems. So you can actually pick and choose, or pick from the profile what sort of adverse events you're going to get. It's pretty hard from that because pretty much they look the same so far. Plasma half-lives, how long does it hang around in your bloodstream? If you gave a single dose to someone, how long does it hang around? So aripiprazole itself hangs around for about 75 hours. The actual drug does the job. It's also got an active metabolite that hangs around for about 94 hours. So on average, it takes about 2 to 3 weeks to reach steady state, at which point you're probably starting to know what the dose is actually going to do. Okay? Brexpiprazole has an inactive metabolite that has a long half-life, but so what? It doesn't really do anything. It just gets cleared afterwards. But it's got a half-life of 91 hours, so the ballpark is still roughly the same. You know, you're talking 2 to 3 weeks, 2 weeks probably to reach steady state. So a couple of weeks before you know what's going on. Drug interactions. The drugs are actually metabolised predominantly through liver enzyme systems. So there's a couple of different, there's families of them. So the ones that we find that are really important in psychiatry tend to be 3A4, which pretty much metabolises almost anything and everything known to modern man. It's one of the key things for actually getting rid of toxins you put in your body. So anything you put in your body, it probably has a role to play. It's in lots of different places. 2D6 is often associated with a lot of the antipsychotics because it's the one that's, many of them are metabolised through. So it's also one that's actually what they call polymorphic. So in different races, you get different expression of this particular enzyme. So, and even within races, you get different numbers of people who do different things. So we know that in most Asian races, most of them are poor 2D6 metabolisers, which means you give them a drug from this that are primarily metabolised by that. They get side effects before you know what's going on, okay? Because they've got to use alternate pathways to break it down, not the main one. So if we look at 2D6 again, you've got a group of people who are ultra fast metabolisers, so they clear drugs really quickly, super fast. So basically you've got to dose them to the eyeballs, like keep upping the dose, and they don't seem to get too many side effects off anything. And then you've got the other group in the middle who are sort of, yeah, just regular. And they just, they're going to, the way they do things is going to be affected by other drugs that affect that enzyme system. So if you've got drugs that are potent inhibitors at 2D6, that means they slow the rate of its usefulness. Therefore, your drug levels are going to go up. You're going to get side effects predominantly, or toxicity. Most likely with these things, it's increased side effects. The same thing goes with your 3A4 system, your inducers and inhibitors. So there are some drugs that will speed them up, in which case, if you speed up the clearance of a drug, the levels go down. So you need bigger doses to do the same job. If you've got inhibitors, then you're going to slow down the rate of clearing it out, and then you're going to increase the levels. So you're going to get either side effects or toxicity. Okay? This is important because some of the most potent inhibitors and inducers, some of them are drugs that we use daily, some of them are actually other regular medical drugs. So we know that the conazole drugs, so the drugs that are used for fungal infections, ketoconazole, iconazole, I can't think of all the rest of them, but conazole thingies. Some of the macrolide antibiotics, so some of the clarithromycin, erythromycin, some of those are actually are they inhibitors or inducers? I forget. I have to look it up. We know that people like to take lots of other healthy good things, don't they? So we know that grapefruit juice is a potent inducer. We know that St John's wort, because St John's wort's good for everything when you're feeling a bit flat, it's actually a potent, is it an inhibitor? Inducer, I think it is. So there are reasons why this becomes really important in individual dosing. Okay, did I change that before you got a chance?
It's just my luck.
Oh, look, you've got it on your... I sent it to your thing.
That's true, I forgot.
Okay, so if we think again a little bit further, and from the early trials, aripiprazole we know causes akathisia, so that motor restlessness, and restlessness in general. It also causes insomnia. They're the two big things it does. Okay, the big things that brexpiprazole does is that it can cause some weight increase. And when I say weight increase, on average we're talking 1 to 2 kilos over 6 weeks. You get a very small number of people who will have an increase of at least 7% of their body weight. So from that perspective, that's something to be mindful of from a metabolic perspective, but it also causes akathisia, but at a slightly lower rate than aripiprazole. So what we're looking at here is these occurred at least at twice the rate of placebo in the trials. So if we had a look at this, there were probably 3 pivotal trials that showed that brexpiprazole is effective. The first one is a randomised placebo-controlled multi-dosing trial. Okay, so the things that are important on this, they measured PANSS scores. Everybody heard of PANSS scores? It's a way of rating positive and negative symptoms. Okay, it's just like a tick sheet sort of thing, and you add up the numbers at the end of the day, and depending on where you sit, you can see different. It gives you an indication of how unwell someone is. Okay, so we have a baseline score. They wanted a mean improvement of at least was it 30%? 50%. 30% improvement was the idea on either that or a CGI, which is a clinical global impression, which is pretty much on a range of different questions. Someone said, yeah, I thought I was better or not, like rating it from 1 to 5 or something.
So the placebo was 30.3.
Okay, so the response rate with placebo is 30.3%, okay? So a lot of people actually drop out of the placebo. You get more dropouts out of the placebo trial because people aren't getting better. 0.25% didn't do much of anything. The big winners are up here, okay? So you've got to have at least 2 milligrams on board. 4 milligrams across the board did a good job.
They do serum levels?
I probably wouldn't. You can do serum levels. You have to be able to do with anything because the coroners like to do them. How meaningful it is anyone's guess, because there's no clear dose-effect relationship, dose-response relationship. So just because you've got the same dose as Fred down the road who's got better doesn't mean you're going to get well. There's no clear relationship there.
I was with antidepressants when I was doing research in the past.
There is with tricyclic antidepressants.
Yeah.
There really isn't with most of your antipsychotics.
Okay.
No. There's a ballpark that's very clear for clozapine where you need to be above a certain level for it to actually be probably in the ballpark of working. And that's useful checking. Mostly it just tells you if somebody took the drug.
Yeah.
Or it gives you an indication of toxicity, which you can probably see by looking at someone in front of you anyway.
They have to check that to make sure they didn't get too high levels.
Well, the problem with clozapine levels, if you're talking about therapeutic drug monitoring, is that they're very fickle. So they can change in an individual for no good reason that we can ever even think of, in spite of them doing the same thing every day. Another thing that is that there's no clear upper limit of effective dosing. We do know that if you get levels over 1,000, you increase the risk of seizures. And that roughly equates in some people to a dose of over 600 milligrams a day. For other people, it might be 400 that's got them up there. So again, there's huge differences from one person to another. And keeping that, trying to make some sweeping statement from that is just not possible. But it's something to think about. The second study, again, the 2 to 4 milligram, we're looking at good response rates, particularly the 4, okay? Not so good with your 2 there. The 1 milligram got a bit of a response rate, that's really interesting. But you're still back in the 31 for your placebo, so that's comparable. And this one, okay, did I just do the same thing? Okay, this is the third trial. It's a flexible dosing trial comparing brexpiprazole with a drug that's already on the market. So basically, people could be given anything from 1 to 4 milligrams a day of brexpiprazole, anything from 10 to 20 of aripiprazole. Depending on what was going on, they did mean scores. Both the improvements were both 6 of one, half a dozen of the other, so considerable. In terms of response rate, so if you're looking for a 30% drop in your PANSS scores or your CGI, we see that we actually did better with the brexpiprazole. And I wonder whether the ones who actually got well, most of them were actually up around the 4 milligram a day mark. And that's quite likely. And for aripiprazole, look, it's hard to know why that did that, but in any case, it's still saying that it works. All right, so it's a maintenance study. Oh, the lights just go out on us. Okay. Okay, maintenance study, stabilised on brexpiprazole. They extended that to a year. They randomised people to either 1 to 4 milligrams or placebo. They were looking at time from when they started the trial to when they got worse or looked like they were going to have a relapse. And they cut the trial short after the first interim analysis, which was like, I think, it's about 4 to 6 months in. They cut it short because there were some clear differences. The brexpiprazole group did so much better than the placebo group. There were lots of people in the placebo, and you would expect that. It's no great surprise. From the short-term studies, looking at tolerability, we looked at akathisia occurs at about 5.8%, weight gain of more than 7%, you're getting about 5% of your patients, compared with placebo. And the degree of severity of those, or the occurrence, is dose-related. So you're going to get more, the higher the doses, the more people you're going to get who have got side effects. Your metabolic syndrome, so they're the things that you worry about. So people developing high blood pressure, cardiac risks, type 2 diabetes, having their cholesterol and triglycerides go a bit off tap. We find that it's a small number, but nonetheless it's there, okay? And in a longer term trial, we get more, okay? So 3% of the population actually experienced that in the 12-month trial. 5.6% who were on the drug for a year or more gained 15 kilos or more. Now, that's a couple of clothes sizes. It's not chicken feed. It's 2 to 3 clothes sizes. So that has significant effects on everybody's systems. It doesn't affect the heart in any particular way, particularly cardiac conduction, okay? So, in pregnancy, no information. So we're not going to use it in people who are pregnant or lactating at this point in time. There's nothing to suggest when they poison rats and rabbits and other rodents that there is a problem with it causing malformations. But when they gave the really big doses, so I think it was the 176 times the upper maximal recommended human dose to rats, they got more pup deaths. How you translate that to people is anybody's guess. I guess my concern is that while there isn't a lot in the literature saying that aripiprazole's good, bad or indifferent, there have been, prior to collecting data, there have been a couple of cases of anencephaly, so babies being lost because their brain's not developing in this and that. So I'm a little bit iffy, and until someone gives me enough figures to actually say that that's not so, I'd still be cautious. I guess because these drugs have long half-lives, there's also the capacity for them to accumulate in a neonate. In terms of lactation, there's still no information, but in rats you got 1 to 2 times the serum concentration in a mum. Now, the arbitrary limit of safety, come on in. Come on in. Come on in up the front. So 1 to 2 times the maternal serum concentrations, you think, oh, Well, I don't know about that because, you know, it's not a straight one-way thing. The drugs go in and out. The arbitrary limit of safety is 10% of the maternal dose, serum concentration. So we're talking big bics here. So this drug has the potential to accumulate in milk, so probably not a really good risk for lactation. In terms of general adverse effects, and I guess this is probably somewhere where this shows this a little bit better, and we've got fatigue occurs with aripiprazole at about twice the rate of brexpiprazole. You get a minor change in appetite, not much. You get the big difference here is weight increase with brexpiprazole. In this one, cardiovascular, you get some small tachycardias, a bit of postural hypotension with aripiprazole, particularly when you start. You don't see that with Brex. Rashes, well, I'll be honest. I think it's too soon to know how many rashes brexpiprazole is going to cause. And you know, they put their blanket warning that there are some people who are allergic to the things, so you can still get angioedema and acute hypersensitivities from these things if you happen to be sensitive to it. And you don't know that until you try it. Neurological effects, so anything that sort of comes from the brain and does that. The big winners here are probably, you get about dizziness at 9% with aripiprazole, 3% with Brex, so there's a bit of a difference there. You get a marginal increase, but it's probably not significant, on extrapyramidal disorders, so that's movement disorders in general, drug-induced Parkinsonism, funny muscle jerks, funny sort of changes in muscle tone, those sorts of things. The other one is akathisia. So when you include akathisia, occurs at about twice the rate with aripiprazole and then brexpiprazole. Headaches, a big winner for aripiprazole, not so much for Brex. The others are pretty much, look, you get a bit of sedation, you get a bit of somnolence. What doesn't cause it? Aspirin gives some people headaches, so who knows? Psychiatric agitation, anxiety. Agitation probably often comes from akathisia, so that restlessness, the whole deal. Insomnia is a big issue for aripiprazole. It's less of an issue for Brex, and you can see that it's comparable to placebo. Anxiety is up there for aripiprazole. The rest of it is pretty self-explanatory. So from that perspective, Brex looks pretty good. The one thing it does do that aripiprazole doesn't do is it does actually elevate prolactin in some people. Not much, but they do say that you should be cautious once it reaches double normal limits. Most people with their elevation in prolactin, and that's important because it's got to do with sexual functioning, reproductive functioning, a whole range of things. So there is bone health, the list goes on. In terms of, so that's something Brex does that aripiprazole doesn't usually. You get I think there's 1 or 2 case reports in the literature with aripiprazole, but that's really unusual. Brexpiprazole, it's perhaps going to be a little more common. Discontinuation rates, look, not much in it at all. So the stuff looks good. Has no problems with food, so you can take it with a big meal, no meal, go for your life. Start at 1 milligrams, you titrate it up to a target of 2 to 4 milligrams over a couple of weeks, a week, 8 days. Reduce the dose by half in severe liver disease, but we're probably going to be very cautious in severe liver disease and renal disease anyway. You get a peak plasma level within 4 hours, but it's got a really long half-life. The stuff hangs around. Take care administering it. We've covered that bit. And then, yeah, that's Brex. So pretty much it looks better than sliced bread, but we wait and see. The clinical experience with it so far is actually pretty good. It seems to be quite well tolerated, and it seems to be doing the job. So I've heard a few people discuss the patients that they've put on. They're still quite low numbers at this point, but it's looking good as an option. So it'll be interesting to see how it comes out, whether they're going to bring that in with bipolar disorder and a few other things. But or whether or not it's going to be used as an adjunct in treatment-resistant depression, because it's going to be expensive for that, because it's not an approved indication. So cost might become a problem.
What's the toxicity in overdose?
Most of these things, you can take bucket loads of them and it doesn't really matter.
Fairly safe one, is it?
Look, most of them are fairly safe. I would think, I did read it. I can look it up for you after we're finished.
No, it's all right. Just wondered if, I mean, a lot of them are relatively safe now.
Look, most of these drugs these days, you get increased side effect profile. Perhaps the most, if someone's overdosed, the big worry is respiratory depression, or if they're getting extrapyramidals and you get a laryngeal spasm or something like that. It's probably less likely with these drugs than with the older ones, and even the level of sedation with this drug is not that great. So you would have to take a considerable amount to actually get you in that threshold. Having said that, some people are very creative in the way that they take overdoses. So simple statements on toxicity are irrelevant. Every overdose is important until it's proven safe. The second drug that I wanted to just briefly talk about was Trinza. And basically, has everyone heard of paliperidone? Yeah? Yeah, okay. So paliperidone comes as an oral tablet, capsule sort of thing, which is really quite a very effective dosing strategy. You've got to give the drug companies a bit of a clap on the back every now and again when they do something good. Paliperidone palmitate, the 1 monthly injectable, they use nanotechnology to do it because all of these new drugs don't lend themselves to the old way of formulating depot injections. So the chemical nature of them means that they don't, they're not stable in that setting. So they've had to be really clever. So with risperidone consta, they did microsphere technology where they got the small particles and stuck them onto little microspheres that break down to water and carbon dioxide. So that was one way of delivering it. This one, they've used nanotechnology to make the particles really small. So you can inject a quantity, it's in a water base again, and it takes time to dissolve. What they did for the 3 monthly is there's a slightly bigger mix of particles. So there's some extra big ones that take a lot longer to break down. So to actually use a 3 monthly injection, you have to have had the 1 monthly for at least 4 months, or for at least 4 injections. Now that's the policy. There are a number of psychiatrists around who think that dosing for 6 months is probably a better gauge of someone being stable. There are others who think maybe you want to keep someone stable for 12 before you go jumping down the 3 monthly path. And I think part of that is that the bean counters in a lot of places tend to think of 3 monthly injections as you see the person once every 3 months, therefore there's no contact, so you limit your contact. In fact, I think what this does is it gives you an opportunity to actually do something else with people. So instead of wasting your time that every time you see them is about arguing over medication or doing something, you can actually do other things in terms of recovery and that. And it depends on how people use those drugs. We're starting to see a little bit of use. Picking the patient's always going to be an issue. So it's certainly an option, particularly for people who are doing well, who might want to move through services or move out of services or even have some shared care with the GP. You can actually do some creative work there. The next 2 slides, 3 slides probably, are really about who knew that they had guidelines for the use of this thing. And we do. So Richard Newton's written, and a group have written practical guidelines on the use in schizophrenia. And I think one of the tricky things with paliperidone is that because it's loaded, you'd use a dose loading strategy to actually administer it. You get an almost steady state. If I'm saying stupid stuff, tell me. What happens is that they give a big dose to start and then a slightly smaller one. They give it in your arm. because you get higher levels that way, and then a month later you get your next one. So that strategy actually gives you, it's like you've been dosing it for 8 months. Okay? So it gives you you could actually even use it on an inpatient unit if you had to. So being able to actually use something like this is actually, it's potentially useful. This is all the who's and what's it's between changing from the Invega Sustenna, which is the 1 monthly, to changing to the 3 monthly. So there's ways that you do it, and it does matter whether the needle goes into your arm or into your glute. And it matters what length needle, because there's no point in putting these things into a lump of fat. And I don't say that meanly. We had a rather charming lady who was coming in for years at one of the facilities I worked in, and she was probably Slavic in origin, tiny little woman, bit round, and she developed some nasty wasting disease and lost an incredible amount of weight. And as the fat stores diminished, she actually became as stiff as a board because of the drugs that she'd been given for so long, and some of them had accumulated in the fat, because they're quite lipophilic. They have to be to cross the blood-brain barrier. So they like fat in some ways. So you've got to be a bit mindful of those things. Alrighty, so that fun, complicated thing. And then they also give you a detailed account of how you manage missed doses. So there's a fair window between, you know, if it's 8 days, you've got plus or minus 4, and then if it's at the 30-day mark, it's plus or minus 8, I think. And so, you know, there's different, with the 3-weekly one, it's plus or minus 2 weeks when you get to the 3 months. This stuff hangs around forever. So it's really important that we match that, because as much as we think this, well, I sometimes think it's funny, the fact is that just because you're sticking a needle in someone doesn't mean they can't miss a dose. You've got to catch them first. You've got to find them, or they've got to present. Okay? So people can still not take their medication by choice, even if they're on depots. Mind you, outcomes are much better with depots, because, in fact, the best treatment, when they did a big long review of outcomes in psychosis, what they found was that clozapine had the best outcomes. Second, third, fourth, fifth, sixth and seventh, maybe second was polypharmacy. Second could have been polypharmacy. It's either that or all of the long-acting injectables. And the reason is that you take taking the medication out of the equation. So that works better than any of the orals at all. So having said all that blather, the only other new drug that we've actually had in the system recently is suvorexant, which is a new hypnotic. So it's a sleeping tablet that's very different from the ones that we currently got. What it acts on is orexin is a hypothalamic neuropeptide. So it's this little molecule thingy that runs around, and it acts on, there's an orexin A and a B, and there are receptors for those. And what they do is they actually keep people awake. So we found that in narcolepsy that there's some sort of strange misworking of that system. So if we use a receptor antagonist, it should promote sleep, and it actually does. I think the aim of the exercise is to shorten the time to sleep onset. So a lot of people with insomnia complain of, one, not being able to get to sleep, and when they do get to sleep, they don't stay asleep. Okay? So it's a little different from depression and those things where people can often be either hypersomnic or an insomniac, and you can also get early morning awakening with depression. So it's a bit slightly different picture. And to be fair, this drug has all of the patients who've got psychiatric disorders were excluded from, anyone on a psychotropic drug was excluded from the trials. Okay, so we really don't know that much about how it's going to behave in a psychiatric population. I know it sounds crazy, doesn't it? Having
Christine, just the reference down there, Norman.
Norman is, it's Jennifer or something like that, and it's from a international clinical practice, or it's from a pharmacy journal. So it's not our friend over at.
Trevor.
No, it's not Trev. No. It's a lady. And Kex is Nick. Yeah. Nick, Judy and Simone wrote that paper. It's been published in 217, so a long time ago. No, it's actually came out in the last couple of months. So it was actually published in Australasian Psychiatry very recently. Mean time to onset, it takes about up to 2 hours for the stuff to work. They advise that you should take it about 30 minutes before you go to bed. It can take anything from 30 minutes to 5 hours to start to work. What we're aiming, if you have a high-fat meal, it gets slower. It lasts about 12 hours, which is not a bad time, because you actually want that intermediate time to people to actually stay asleep, okay? It's primarily hepatically metabolised, mostly through the cytochrome P450-3A system and a little bit of 2C19 thrown in for good measure. You've got to be cautious with potent inhibitors, because what you're going to get is more side effects. Not necessarily more greater efficacy, but you might. Age doesn't affect the pharmacokinetics of the drugs, so just because you're older, you're young, it doesn't make a lot of difference. But it does matter if you've got really bad liver function. If you're female and you've got a little bit of put around you, so you've got some degree of obesity, you are at more risk of actually having higher levels of the drug. Winner for us girls again. Hey, look, you can all laugh. We all win with the cardiovascular stuff, though, because we've got estrogen protecting us until we hit menopause. So we're a little better off there. Yeah, and you know, we tend to last longer than you guys do now. Whether we send you to your graves early or not, it's another matter entirely. Okay, so the interesting thing is that, as I said, no people on psychotropic drugs were included in these trials. There are no comparisons with established hypnotic agents.
Sorry to interrupt you. Did they give a reason why psychiatric patients were excluded? Was it just that the control group or the group of...
I think the majority of insomniacs don't necessarily have a psychiatric diagnosis. It has a general, yeah. The fact that it's actually going to be used in psychiatric disorders where sleep is a huge issue is a secondary concern, and we need to wait for those sorts of information, or people try it. Young people, sorry?
Excuse me, was that also one of the exclusion factors that they didn't have a psychiatric background?
The exclusion factor was they weren't taking psychotropic drugs. Which doesn't mean that you've got a known psychiatric disorder. It means that you weren't taking a psychiatric drug. Yeah. They do exclude them from a lot of regular trials, though. And it could be for any number of reasons. And I think one of the other things you've got to realise is that a number of trials are actually done in the US where they pay patients to do these things. So you often get recycled patients in through these things because they get good money. So sometimes until you actually put the drug out in the real world, you don't really know what it's actually doing, or you don't get a really good idea or good feel for it until you've seen it work. In the two trials that they used, they gave young adults or younger adults, 16 to 64 years, they got 20 to 40 milligrams a day. The over 64s took 15 to 30, so they cut the dose down just a little bit. And at all assessment points, the larger dose in each area was more successful. Interestingly, we have 15 and 20 milligrams here, because that's what's marketed and approved. Okay, so what we do find with these doses is that you do get a reduced time to sleep latency. So in other words, the time it takes you to fall asleep is not as long, and your increased sleep time. So they did actually gain some sleep. They did note that with the bigger doses, you were more likely to get rebound insomnia, and you do get that with your other hypnotics as well. This is a fancy way of saying that they've got varying ways of measuring this. The difference from placebo at 3 months, 6 to 7 minutes. So your onset of sleep was 6 to 7 minutes better, and I believe it's about 39 minutes better at 3 months, the length of time that you actually sleep. And for people who rate their own quality of sleep, that can be significant. In a 1-year study, the under 65s were 40, the over 65s 30, and after 1 month they found that the sleep latency improved by 18 minutes, sleep maintenance by 39, and the improvements were maintained for the whole study. So in other words, this is a drug that's actually being looked at for long-term use in insomnia, not short-term use like we see with the benzodiazepines and the Z drugs. The cute thing about this is that you do get some hangover drowsiness in the morning. You do get a bit of somnolence that's complained of with the smaller doses, which are the doses that we've got here. And it's more common in women than men. There's no difference in terms of age. So the younger and older patients, doesn't matter. Effects on your driving skills are minimal. Most of the trials showed no memory effects, but one trial showed that you got, reduced word recalls in the morning after dosing, and some people got increased body sway. So that's, has anyone ever done those sorts of things? Have you ever tried to stand still and not move? You tend to go like this. I'm exaggerating, but you do tend to sway. And unless you've got a baby on your hip where you're deliberately doing it, you often don't notice. But if you are swaying more, it's measurable and you can actually see it. So you can feel a little less steady on your feet. Other effects that are noted are fatigue, dry mouth, dyspepsia, gastric injury, and I imagine that these are all dose related as well. So the higher the dose, the more likely you are to get them. You can also get a bit of peripheral edema. The rare stuff is somnambulism, so sleepwalking, sleep paralysis, or hypnagogic or hypnopompic hallucinations. So that's sort of the funny things that you experience either on going to sleep or waking up. Okay, and they're mostly in the bigger 1-year study. 30 minutes before retiring you take it, caution driving machinery, avoid alcohol, although there are some case reports nowadays and some small case series where they're actually using it in patients who have alcohol problems. And it's because it works very differently. Alcohol and benzodiazepines is really bad because they actually work through the same system and they actually cause, together they cause significant respiratory depression. So you've got to be really careful. There's no information on its use in pregnancy and lactation, to nobody's great surprise. It's designed to be used long term, so the idea is you start it, you reassess its usefulness in 3 months and see whether you need to continue. Where it sits in therapy is anybody's guess because we have no real comparative data with anything else, whether it's better, worse or anything. They are starting to use it in people with substance use disorders as well as a hypnotic. So there's some interesting work going on with patients taking cocaine, some with alcohol. Haven't seen any with ice yet, which is probably our bugbear at the moment, but this cute little, this complicated whatever really was put in to try and have a look at where it might sit in the scheme of things. And the only important things are, how long does it take to work? So you get your Tmax, you imagine it starts working before it hits Tmax. So most of them are fairly short. And then how long will it last? You don't want stuff lasting 70 hours. Not if you've got to get up and go somewhere in the morning. Ideally, you want something that's sort of around the 10, 12 hour mark. because it gives. So drugs like lorazepam is really good. Temazepam's roughly in that ballpark. On average, it's about 10-12 hours as well. So it really is about how do these work and what are they actually intended for. So for this one, it looks like it's got a relatively short onset and it hangs around for a bit. So probably ideal for getting people off to sleep and keeping them there. Whether it's useful or not in the longer term, time will tell. And that's the end of my slideshow. Now, having got this far, there are some, as I say, brexpiprazole is probably in the pipeline for developing a long-acting injectable. We've probably got another drug from this same class coming out as an antipsychotic, cariprazine. It's available overseas at the moment, and it's, look, you can never be sure with the TGA how long something's going to take to get here, and they don't tend to approve things until a drug's actually had some local experience either. And it costs money to actually present it to the TGA, so unless they're going to get a marketplace, who knows. In terms of other treatments, look, vortioxetine was probably the last antidepressant we got that was anywhere useful. And it has its own issues in terms of nausea and that. It's got some tolerability issues. And that was a couple of years ago. So in the short term, we're probably not going to see too much. What we are seeing a lot of is repurposing other drugs. So drugs that are being used currently for other indications are being looked at to see whether they might have a role in psychiatry. So I know that some of the anti-inflammatory drugs, so the non-steroidal anti-inflammatories, have been tried in bipolar disorder. They've also been tried in schizophrenia and depression, and part of that is because there seems to be an inflammatory basis to these disorders. So if we can switch off some of the inflammation, maybe we can improve outcomes. The big issues, again, are tolerability with those sorts of things. There are a lot of complementary medicines, if you like, or alternative medicines with sort of like essential amino acidy sort of things. So everybody knows we probably should have N-acetylcysteine in the drinking water because it's good for everything. We should probably, S-adenosine methionine is SAMI, it's used in depression. We see that glutathione's being used. We can see that D-cycloserine's being used also as an antioxidant. So we're looking at ways of changing the way we think and feel, and hopefully get some better cognition going, so people having clearer minds, being able to more clearly do things. In terms of the other, not a lot on the horizon, but we are getting creative, I'll give it that. So, questions, anyone? Bored you all witless, excellent.
No. Wow. No, I just know that down in Geelong, Michael Burt has been doing a lot of studies on antioxidants.
Yes, he has. There's
how's that going? I haven't heard for ages.
They've done some good stuff and got some outcomes with bipolar disorder and depression. I think they're doing depression at the moment, and I know there's a study going on using N-acetylcysteine in patients with schizophrenia, but that's centred up in Melbourne, but it's linked with the same, I mean, the people who are doing it are, there's sort of some collegiate process going on there. So
Well, he's just finding good responses with the combination of...
I think the other thing that we need to be aware of is that these things don't work when you don't give them. So anything's only good while you're taking it. And these drugs don't hang around for a long time. So when we use drugs like SAMI and NAC and all of those things, they've got relatively short times in the body, so you've got to keep taking them for it to be actually good. Once you start to increase the doses, tolerability becomes a bit of a factor, so you get a lot of gastrointestinal upset if you double up doses and things, thinking you're doing a better job. I think we're just basically getting more creative. I don't know if any of you went to the Bipolar Disorders Conference recently in Melbourne. The Australian Society for Depressive Disorders, or Depressive and Other Mood Disorders or something, or Bipolar and Depressive Disorders, I can't work it out. They had a conference in Melbourne, so that was... yeah, it was expensive, you're right. Was it not so expensive for people who don't work as a practitioner? The client, the consumer and carer fees were quite reasonable and the presentations were very good, very good. They actually got the guy from that to actually go down to Geelong and present down there, probably because Michael was in charge, but fabulous speakers, fabulous. But pretty much they were saying the same things. We're getting very creative in how we actually use our drugs. Does anyone have any questions? We can turn this off probably.